While we wait for Karen to get that turned on, we'll go ahead and get started. Thank you guys for joining us today in our last webinar of the year. So Merry Christmas to all celebrating and Happy New Year to everyone. This is going to be the FLaNET webinar on PRRT. We have our nuclear medicine techs and supervisor here on the call. I'll let them introduce themselves. We'll go ahead and start with Kate-Lynn. Just go ahead.
Hello, my name's Kate-Lynn. I work in nuclear medicine at Moffitt, and I coordinate all of the Lutathera treatments we offered here.
And we have Karen on as well.
Hi, I'm Karen. I'm the supervisor in nuclear medicine, along with the other technologists that administer the radiopharmaceutical.
All right. So to get us started, I know you briefly introduced your roles, but Kate-Lynn, you work on, setting up the patients from the start. So can you give us a little bit of background on which patients might be coming your way? And Karen, feel free to chime in as well. Where in the process you guys would jump in, and which patients would be, eligible in broad sense for this type of therapy.
Sure. So after, they see the GI team and they get their PET scan, they come into interventional radiology. We'll see Dr. El Haddad and Nakia Norton, his nurse practitioner. The PET scan will show if they have the uptake for the receptors and if they are a good candidate for the Lutathera treatment. And if they agree with that, we are going to move forward with that. After the consult, we will obtain their insurance. That's where we start the insurance process. The insurance process is probably the most frustrating part in this process, just because we have to make sure, all of our patients are covered. We don't want anyone to be surprised with a huge bill coming in the mail. So the insurance, depending on the type of insurance, it could take anywhere from usually between 2 to 3 weeks, but we have seen, some insurances that take up to 4 weeks. And then if for whatever reason, patients aren't approved through insurance, then we have to, go through the next steps for, free drug approval or copay assistance. And then after we finally obtain the approval with the insurance authorization, we can then actually move forward into scheduling. And then the scheduling is pretty straightforward after, like I said, after we get the insurance. We essentially I'll call the patient directly. And we figure out, good if they're on Sandostatin, then we have to obviously, wait the 4 weeks to make sure, the 28 days after they've had their last one to coordinate their first starting the Lutathera treatment. And how the day itself looks is that, since there's 4 injections, they'll come in a total of 4 times. They get blood work done. They will then go to the GI clinic where they'll see a member of Dr. Strasberg's team or Dr. Hayter's team, typically here at Moffitt at least. After they have their follow-up and their labs are approved, they will then go to the infusion center where they actually start the treatment for the day. They'll get all the fluids, amino acid and fluid injections. And then after that has run its course, the nuclear medicine technologist will come up to the infusion center. We will escort them down to the nuclear medicine department. We'll actually give them the Lutathera, the lutetium-177 injection. After that has run its course, we've returned them to the infusion center where they will finish out the remainder of their fluids for the day. And then if they are on Sandostatin, they will get their Sandostatin injection after that, the end of the day before they go home.
Thank you. That was a very comprehensive overview of everything that patients have to do from start to finish. What questions do you feel like you get from patients, Karen, up front? You've kind of seen us all the way through from the NETTER-1 study, from when all of this was brand new, through now where we're getting into the alpha PRRT and things like that. So can you give us some insights, starting from the beginning and where we are now, that you have from patients?
The patients, the NET patients with this are very educated. So to be honest, by the time they get to nuclear medicine, they have had either on their own, along with all the consults, they're very much educated. We review, it's usually radiation precautions that come my way. That can be kind of confusing, but actually this pharmaceutical is very easy to work with. It's just a little over a 6-day half-life, which means that in 6 days, half of it was gone from your body, just from a physical standpoint of the isotope. So we give them, it's handwritten just because they have the research. and the consult, and then a handwritten form. We kind of review it before the injection, just to make sure they understand it. It's just a little bit of radiation precautions that they take home for 2 to 3 days. But I would say that's the most question that comes our way by the time we get the therapy. And then we routinely talk to them throughout the therapy. I think the biggest thing is a contact. They have Kate-Lynn's contact, my contact, and on the sheet they have the radiation safety officer's contact. So here at Moffitt, the patients can easily call us if they end up going home and having a question. I think we get a lot of that later on, but the patients are very educated. So
yeah, absolutely. I think the NET patients in general are probably one of the most educated groups on their disease that I've worked with. You mentioned 2 to 3 days. A lot of the paperwork usually says 7 days. The different radiopharmaceuticals, whether it's Lutathera or the newer drugs, the alpha therapy, there tends to be a lot of conflicting information that patients hear from their providers, nuclear medicine, the text, the online, they go online. So can you kind of explain why we have these precautions and what the true danger is to those around you?
Within 3 days, because it is excreted through the urine, most of the dose is out of the body within that time. They'll extend it to 7 days, depending on everyone's home situation. So that can change per patient. If there's children in the home, if there's a pregnant woman, we extend that radiation precautions. It's a beta emitter, so it doesn't extend too far. So you can stay in the same house if you keep a little bit of a distance, even if it's children. We do like to have a separate bathroom because of the urine contamination. The biggest thing to worry about with Lutathera as far as radiation safety goes is not so much the exposure of the isotope, but the contamination, because that can be tracked throughout the home. The biggest thing to remember anytime you're working with these kind of isotopes is washing your hands, especially before preparing a meal. So that Lutathera will wash off actually very simply. So if you wash your hand 2 or 3 times, if your hands are contaminated with any kind of urine per se, it will come off. And so the key is real attention to hygiene during that time. So we probably do, that's why it's confusing, because we individualize the radiation safety for the patient. If it's just the person alone, obviously it's a little different than family members or anything like that. We do take in consideration travel. Going home, we do ask them to sit a little bit of distance as much as they can in the car from the driver. Those are just little, and we individualize once we talk to the patients and find out what they need.
And pets, that's a big question that we get. Can my pet sleep with me? Can we be around my pet? Things like that.
Yeah, we do actually. It's interesting. We've learned a lot about that. Pets, we recommend they don't sit on your lap if you have a cat or a small dog for the first 2 to 3 days, because it's excreted into the bladder. Your bladder will hold a lot of that activity first off. And then we would take very much precaution. You wouldn't think about it, but we don't like the pets to let them lick you, for instance, because that actually can spread contamination. So just a little bit of key factors, I would say for 3 days would be probably a good time to watch your pets and then how you interact with them.
Okay. And is it just the urine, or is it the sweat, saliva, other body?
There's a small amount in, if they vomit, for instance, we would want to know that during the first 24 hours. There's a small amount in saliva, but we concentrate on the urine just because it is primarily excreted that, but you do, bodily fluids, we do pay a little bit of attention to that, but it is primarily the urine, but it's mostly hygiene. Everyone wants to say they're particular, but it's just we increase that, more showers, wash your hands more, just more attention to that.
Kate-Lynn, do you have any insight, or can you tell us a little bit more about what the most common holdups are in that process? So you talked about how patients, need to meet with their providers first, discuss that this is appropriate. From there, you begin the paperwork. That paperwork portion, I think a lot of people don't think about that often, but what are the most common snags that you hit in that?
Sure. So we actually we have a whole team in financial clearance here that is dedicated to getting our patients approved. So after I get this, we have to get the patients to, sign the insurance paperwork. And so after I get that returned to me, I send it out to financial clearance, and they're the ones who actually start the process. But usually from what I hear, it's just back and forth with insurance companies, unfortunately. Like a lot of the times it'll be the insurance companies will approve the actual, Lutathera, but they won't approve the amino acids, which we have to give the amino acids to, before the Lutathera treatment. So it's just honestly just a back and forth. Sometimes we have to do a peer-to-peer, which Dr. El Haddad will have to speak to a physician at the insurance company to justify the reasoning why we need, the treatment to be approved. So it's just honestly just a lot of back and forth with insurance companies. That's usually, but it's mostly, just like, again, just back and forth. We have to wait for the actual physical documentation that states, approved. And a lot of times patients will get frustrated just because, they're waiting. And that is what I hear most, is what they're frustrating most about the patients, for the patients at least. And then let's see. And then if for whatever reason, like I said, if we have to go through all this before we can actually, if they get denied through the insurance, then we start, the copay assistant or the free drug approval, which is through Novartis. And that usually, that takes time also. So that's typically the snags we hit. And then we haven't had too many issues with actually obtaining doses, because the doses, they're not made here at Moffitt. They're made at nuclear facilities that come from, either New Jersey or Italy. And then, so sometimes they'll have production issues, which is very unfortunate if we can't really tell when it's going to happen, deep production issues. So when that happens, either, we won't have a dose, we're supposed to be having a dose coming in, it doesn't come in, then we have to, push the patient out another day or two, which is unfortunate because a lot of patients, have to schedule everything around this. Which doesn't happen too often, like I said, but sometimes, we have to compete with all the other facilities trying to get these doses. But typically just around the holidays are the most troubling for us.
So a typical insurance, a signature of consent to an insurance approval, what would you say the average amount of time it takes?
Usually it's about 2 to 3 weeks. It doesn't usually take longer than that. But again, it just depends on the type of insurance. Medicare is usually pretty quick. Blue Cross Blue Shield sometimes gives us some, kickbacks issues. And United's usually also on like the 3-week mark. You have other ones that are called, Simply Healthcare, and those take the longest, about 4 weeks. So it just depends, honestly. But usually it's about 3 to 4 weeks, or 2 to 3 weeks.
Okay. And so and then from the time of approval to time of scheduling the treatment, what does that turnaround time usually take?
Well, so usually, like, normally we can order doses usually about 2 weeks out. It usually takes about that long just to get a dose created and shipped to us. But sometimes, like I said, we have to coordinate it around, if the patients are on Sandostatin analog, then we have to wait 28 days from their previous injection. So it just depends on the last one they had. If they just had one, then we have to, wait the 4 weeks, or we have to wait the 3 weeks. But so it just depends on their schedule, their timing and scheduling when they want to do treatment. But normally around, besides the holidays, just because again, everyone's trying to not get treatment around, Christmas or New Year's. But usually we'll get a dose within about 2.5 weeks.
Okay. And so for patients, go ahead, Karen.
Oh, I'm sorry. I was just, as you were talking, the one thing we do talk about, we give the patients, when it comes to radiation precautions, a card to carry with them. I would recommend that. It's just an easy card to put in the wallet, because if traveling, for instance, there's a lot of airport and cruises they have very sensitive machines. So this card will let them know. A lot of times the instruments will tell them it's probably a medical procedure, but it just simplifies their life. If you pull out the card, it has the dose, the date, our contacts, and then I would just recommend that to make it easier for people traveling.
That's a very good point. And for those listening or watching this back later, every center has its own protocols, right? Every process, every place will have different protocols for how they communicate with you, what the card looks like, what that information looks like, the turnaround times. I would assume are pretty universal, but also it depends on the volume of the center that you're going to, how many treatments they're doing a week, how much availability they have, right, to actually treat the patients. And so all of these things can vary a little. We're giving you our Moffitt experience here, but that may differ from place to place. So I think the take home for me as a patient would be asking those questions up front. So in that consult, making sure that you're asking to know what you can do, what you can do to expedite the process or not hold up the process, at least to keep things moving, who your primary contact person should be, especially in this space where you have a medical oncology team and you have a nuclear medicine or IR team that's actually helping as well, or really driving it, but your face person is usually your medical oncology team. So, and that looks different at different places as well. So just keeping that in mind, I think. Kate-Lynn, you mentioned those turnaround times and, the average times. And I think that's where this is unlike other therapies where chemotherapy or oral medications where you meet with a doctor today and you can have the drug in hand or be infused next week. So those are things to keep in mind as well. So if we talk best case scenario, from the minute you talk to your doctor to dosing, we're looking at least 4-5 weeks. It's not going to happen overnight in most cases. Now, Karen, you've been involved in a lot of trials, so let's veer a little bit on to that topic where things look a little bit different. So what does the setup look like from your experience? And I can talk a little bit on from the MedOnc side, what that looks like.
Okay. You're talking about the administration side?
The administration and then the setup processes. So these timelines look a little bit different as well, right, on a trial.
Right. Well, during a trial, you follow the protocol and it can be a little different. We did the Nutter trials here at Moffitt, and so our administration is using the vial method. They have different places can do different administrations, but we find that to be more within our control. We can reduce doses. So if the doctor decides that they want to give you less for a treatment, we can alter that on site. So we follow that. During the trials, I think the biggest change from the trial to the FDA approved is the amino acids. They're tolerated a lot more. So if you were reading or Googling about the trial versus what we do now, that's probably the biggest difference is patients tolerate this very well compared to, that was a lot of amino acids that they took, just not the 2 that they're given now. And that's a big difference when it comes to tolerating the whole procedure. It's actually pretty easy on the patients. It lasts a long time. You're probably here 5 to 6 hours, and we do some measurements before you leave. But in nuclear medicine, they're probably spending about an hour and a half maybe, but closer to an hour. And then we do the administration. It's simple. You actually wouldn't even know you're having it done. We piggyback the administration onto the amino acid line. And then after 30 minutes, we take an image of the injection site to make sure there's no infiltration of their dose. We want to make sure it didn't get into the tissue. And then you return to the infusion center for the rest of the amino acids. And then sandostatin, like Kate-Lynn had mentioned, we wait an hour after the amino acids to administer that before they can go home. So I think toleration of the procedure and how people might think that it's closer to a chemo, but it's a lot easier than that. I think on patients in general, they do very well. I would say in general, the contact, like you say, in between the administrations, they will contact the clinic here at Moffitt.
Mm-hmm. And you mentioned sandostatin, but this would apply sandostatin, lanreotide, or somatostatin. So whichever long-acting somatostatin a patient is on, there is a washout. Can you explain that washout a little bit for patients? Why that's needed?
What are you talking? I'm sorry. Say that again.
Why they need to be off of it for 4 weeks?
The Lutathera is tagged as an analog to somatostatin, so you don't want those receptors filled with stable activity. We want your body to absorb it. So basically, it would block the absorption for that. So that's why we actually will refer to the doctor as to the time frame. Sometimes he can alter that based on the patient, but in general, those are the time frames that we wait. But some patients are on different, instead of 4 weeks, they're on every 2 weeks or 3 weeks. And so we look to the referring physicians to let us know when we start or how we do that. That's always a medical decision. And we coordinate based on that.
And so before you guys get to nuclear medicine, if you are on a clinical trial, the approval process is a little bit different. So it's not we don't run through insurance for the actual PRRT or lutetium alpha emitter, whatever it may be that you're on, the type of PRRT. That's usually provided by the clinical trial, unless it's a standard, what we call a standard of care clinical trial. So if we're looking at, there are some trials that are comparing Lutathera to another drug, in which case both are approved for the patient population, and that process would most likely follow the insurance approval. But if it's a new drug or a new company making a similar drug, that process is initiated and coordinated by your clinical trial coordinator and your medical oncology team at most institutions. So the holdup or the process to treatment day is dependent on which slots were given from the sponsor of the trial. So that is not so much in our hands, but that information would be communicated to the patient in the beginning of the trial. And usually what happens is, in those cases, we're given a dosing slot. So we're told by the sponsor, we can treat a patient on this day. We've already coordinated on the back end with Karen, with Kate-Lynn, with the nuclear medicine team, and made sure that that dosing day works. And then we work backwards and we find a patient that fits into that timeline who's waiting on this trial or is eligible for that trial at that given time. So things look a little bit different, but the treatment administration process on the day of treatment is almost identical, unless there's extra blood draws or extra scans that you might have that are part of the research protocol. Do you guys have any common questions that you get asked a lot from patients by the time they get to you on treatment day or beforehand?
Were you referring to me on that?
Either one of you, whoever's
okay. Trying to think. Like I said, they're well educated on treatment day. A lot of times it's family members that ask the question as well. Here at our institution, we like to include family members before we do the administration. Once administration is done, they kind of wait in the waiting room and not in the room. They're on a normal diet. We encourage fluids and stuff, but we like to encourage them to ask us any questions. Like I said, most of it is on radiation safety. Sometimes they'll refer for our department. If they ask us a medical question, we always refer it back to the clinic. So typically there's not a lot of questions. Y'all are very good. They have a clinic visit the day before we do the administration. So a lot of those questions are actually taken care of by Dr. Strasberg or Dr. Hader's team. So I actually don't hear a lot of the medical side questions. It's always typically related to the restrictions, and I think there's that confusion with distance. And basically we like to, for us, the easiest way to explain it is, if you had a cold, would you sit right next to somebody, or you would put a little distance between you and that person? That is the basic concept of 6 feet away for so many days. It's really just being mindful of a little bit of distance. If you're watching a movie, instead of sitting right beside somebody, you're gonna, put a little bit of distance between you. And it's an easy procedure or therapy to deal with the radiation safety side. That can be explained and taught. It's the first one that you get a lot of the information, and by the time the patients are at their 4th treatment, they could be teaching other people. I mean, they know it very well at that time. So we probably do a little more attention to, like I said before, patients that have children or grandchildren. They want to know if they can visit during the time frame. So we just look at, we have a radiation safety officer that can actually determine dosimetry and exactly from what the dose that the patient got, what is appropriate if grandchildren want to visit, and they can do all that on a case-by-case basis. So it's very individualized as far as that go, but this the general, what we give the patients for basically the 3 days extended to the 7 days is pretty standard across the board, I would think.
And Kate-Lynn, do you think you had unmuted? You have common questions?
No, actually, basically what Karen stated, mostly it's just radiation safety questions. A lot of patients are just a little concerned when they come in. They've never done a treatment like this before, and that's mainly as their concerns is just how are they going to stay safe, keep their loved ones safe. And I get the questions with the dogs all the time, like what do we do with our pets? But that's typically the most questions we get. Besides, I mean, I'll get patients that call me just asking for insurance authorization updates, but that's typically all we receive here in nuclear medicine, at least.
What questions do you think patients should be asking from your experience with these therapies? And would that question differ for you for patients going on Lutathera or beta emitters or alpha emitters? Like, is there
I think, well, the alpha emitters, they have like the radium alpha emitters and stuff. There's no real radiation precautions, especially for exposure to other people. So that's an easier type treatment to for us to do it from the radiation side. It all depends on how that isotope's excreted, but I think the one thing that I would tell people to get more radiation safety personalized instruction if there's a caretaker involved or there's incontinence. That also has to be taken into account. Those patients need to bring extra undergarments, for instance. If there's pull-ups or that sort of thing, we'll go over. That needs to be stored in a bag and not go out to normal trash for 7 days. We go over that. But I would say those are the two biggest items. Caretakers, wear gloves when handling bedpans, those kind of things. It's a little more detail in those cases. So I would tell the patients that should be addressed at the institution with their radiation safety officer so that they truly understand what needs to be done.
Kate-Lynn, can you think of anything else?
To be honest, not really. Like Karen said, a lot of our patients already know a lot when they come to us. So the questions they do have, they're already asking, which is mostly about radiation safety. So yeah.
I would say too that just for patients to be aware that the technologist that's administering the isotope will not be able to answer questions of, will this help me? How long will I feel? All that has to, and we will routinely send them back to the clinic to answer those questions. But as a technologist, that's out of our scope of practice. So we concentrate on the isotope, the administration, and that's our specialty. But when it comes to, will it help? How long will I feel before I feel different, or those kind of questions actually have to be answered by the physician side.
Right. And for a patient who's never heard of PRRT, and this is maybe it's the first therapy they're getting after an injection, what would be one takeaway that you'd have for them just to kind of, one, ease their mind, and two, give them a very short overview of what this will look like for them?
I would say, in general, for us, it's one of our easiest therapies. When it comes to the radioactive, I think that's the part that's uncomfortable, but lutetium is an isotope that's very easy to deal with. It has a relatively short half-life, but long enough to do the therapy part. It's a beta emitter, so it doesn't, it only extends into the tissue. So once it's into your body, it's doing the work towards the tumors inside your body, and what's not needed is actually excreted in the urine. So I think that from a standpoint in our department, lutetium is a good isotope to work with. It's a good isotope for the patient, so they shouldn't fear the fact that it's radioactive. It's not a high energy isotope, meaning that it's not a lot of radiation to the people around you. Even though we give you extra precautions, it's not, you would be admitted to the hospital as an inpatient if you were a real risk to people. So according to the state and our regulations on radioactivity, we let you leave. So you're not in isolation. So that should, I think, be the first thing, that yes, it's radioactive, but it's something that is easy to work with. So I think the fear factor should probably be removed on that, and that basically replaced with the education, just to keep it, you'll be safe anyway, but we like to just go the extra mile to, keep the contamination, meaning the urine from spreading in the house. Even if it does, it would decay to nothing over a period of time. So, but it's our job to make it as best as possible. So that would probably be the takeaway, to remove the fear, in that it's a very good treatment and easy to do.
Mhm. Thank you. I think that's all been very helpful, especially for somebody who's had no experience with this and brand new to PRRT. I think this will definitely be a good resource for those rewatching this or have never gotten this treatment. For those who are on the call, is there anybody that has any questions or comments? Feel free to either type in the chat or unmute yourself and chime in. And Dr. Strasberg and Tiffany, if you have anything to add or comment on, also feel free, please.
Thanks, Tammy. I just want to say thank you. That was actually really informative, even to me, to hear about the logistics. And so I really appreciate it.
Yeah, I think a lot of times we, being on the coordinating side, we don't think about the fact that we're not part of that treatment throughout the whole day. We each have a little bit of a role in it, but we're not with the patient the entire day. So, I think Kate-Lynn and Karen, you guys are probably the most hands-on during that day and get to see that whole life cycle from start to finish, which is nice. And I recommend for anybody on the call who's not a patient or rewatching this later, as a coordinator, as a provider, I always like to shadow each thing that I'm going to be talking to a patient about before we're doing this on a regular basis. And I find that to be very helpful for me to be able to relay that back to the next patient that I explain something to. Okay, it doesn't look like we have any questions or anything of that sort. Kate-Lynn, Karen, any last words before we sign off?
No, just when it comes to the patients, I think communication, for that first visit, who do you communicate for? You touched on that, but I think when they get home, I know that we are very open to people calling, and even if it's not for our department, we can find the answers. We do a lot of communication, you and I and the whole team behind the scenes, and that you shouldn't go unanswered questions. I would say ask questions of your provider, and make sure that you're comfortable. I think.
Absolutely. All right, well, thank you both so much. I know we've been looking forward to this. As something that has been requested a lot. So I know this is going to be a resource that lives on for quite some time for patients. And thank you so much for your time, for everything you do for us every day. I don't think this place would run not even half as well as it does with you on board. So anything and everything we can do to keep you happy.
We enjoy it, to be honest. We enjoy the patients. We get to know them, and it's a good two-way therapy that I think that it's very positive here.
Yes, and they love you too. I can't tell you how many times I hear that they love your team and they know each of you by name, which usually it's, when they go down to get their blood drawn or anything, if they like somebody, they'll ask for that name and they'll write it down. But you guys, they all know by heart, and they ask about you even long after they're done with therapy. anytime we get a patient who's a repeat to nuclear medicine, they're like, yeah, like if you can get me more stuff in that department, I'm happy to. So
Good, that's good to hear.
Well, we do try to make this as easy as possible for all of our patients. So we're always here to answer any questions, and it's a whole team effort.
it is, absolutely. All right, well, thank you all so much. Happy New Year, and we'll touch base hopefully in the new year and set something like this up again based
Sure.
on patient questions that come through.
Thank you.
Absolutely. Thank you.
Take care, everyone. Bye-bye.